So we've been talking about aneurysmal disease, dissection disease, and we know that abdominal aortic aneurysms are the most common. What I want to address here, and feel free to jump in, raise your hand if you have a question in the middle, please interrupt. I want this to be interactive, that there's often, like Dr. Gagne said, some associated aneurysms that are seen with AAA. And one of the things we're going to continue to harp on throughout this is the minimally invasive approach that we're allowed to take now because of the devices and the techniques that have come out. So, patients in the past who were 85 or 90 years old and had an aneurysm that everybody knew about, but no one wanted to treat for fear of hurting the patient, can actually be treated very well now with the devices we have and with minimal morbidity. We often have abnormal anatomy, which we've talked about earlier today, including the need for fenestrated devices to move higher into that pararenal segment. Or we have enlargement of the entire aortoiliac segment, including the pelvic circulation, which makes it a little bit harder to use conventional stent grafts and effectively treat patients, especially younger patients. Go ahead to the next one. So for screening, and I think, Steve, to your point, this is a Medicare issue. Medicare reimburses a one-time screening by abdominal ultrasound for patients to look for AAA. At-risk patients, for people who don't know, are family history of AAA, or males in the 65 to 75 range who have smoked at least 100 cigarettes. Now, that being said, obviously, if you see a patient in your office who's a female and who's 85, but has a pulsatile abdominal mass, they clearly qualify for screening. But these are the Medicare guidelines for screening for abdominal aortic aneurysm. To echo what Dr. Shu said, a AAA threshold for repair is 5.5 centimeters, but I strongly agree with what was said about the idea once they hit 5 centimeters, those patients are by and large going to be treated at some point. And I think there's a couple of big things in my practice that I tend to use as modifiers for that size. So if you have an 80-pound female who has a 5 centimeter AAA, that's a lot different than a 6'2" guy who has a 5 centimeter AAA. So gender certainly has an impact, BMI, aneurysm location or appearance, and these are subtler things that the surgeon will differentiate in terms of where the aneurysm is located, how it looks, and we have some aneurysms that just have what we call an ugly appearance to them in terms of risk of rupture, and that'll alter the size at which we decide to follow them or to intervene on them. So to that point, I agree. I like to know about aneurysms early, and I think for referring doctors to let us in on it early, we're happy to follow those patients, even if they're only 3.5, 4 centimeters. We can keep an eye on them. We can get an idea of what their anatomy is and if and when they need to be repaired. This is the trial that was done in this country, looking at why we should repair aneurysms at 5.5 centimeters. To the point, this was an interesting trial because it compared, this is called the ATOM trial, it compared medical management, so watching a AAA, versus open repair. So that's a big hurdle to be able to say that it was equivalent. And below 5.5 centimeters, there was no difference. And that's with open repair. So if you put endovascular repair in, there's even less of a difference because open repair would have been much more harmful to patients. So I think it's reasonable, but once you get into that 5 centimeter range, it becomes time to think about treating. Our treatment of AAA has changed dramatically in the last 15 to 20 years. This is the old open abdomen with a big exposure of the aneurysm. And now I would say the vast majority of the aneurysms we treat are done percutaneously with no incisions at all. I would say about a third to a half of the patients that I treat are done awake without a general anesthetic. So you can do a regional anesthetic or a local anesthetic and really be able to treat patients who are older, sicker, with good effectiveness. So now that we have an idea of what's out there with AAA and when to treat them, but peripheral aneurysms are a little more vague, and I think even within the vascular surgery community, they're a little more vague. We don't have a lot of information. There's not been nearly the number of big trials and case reports that have shown when to fix peripheral aneurysms, how often they occur. We know that the presence of a AAA is more common than the inverse. So a patient who has a femoral aneurysm or a popliteal aneurysm, depending on which paper you read, about 2/3 to 3/4 of those patients will have a AAA. The difference is that we usually identify AAAs, not the other way around. So when we identify a AAA, how do we know who might have a peripheral aneurysm also? Because you may not identify a femoral or a popliteal aneurysm. They're rarer and they're harder to diagnose. Our treatment is different for them as well. In my practice at least, femoral aneurysms are more benign. They tend to have less problems. Popliteal aneurysms are a trickier entity. They, instead of rupture, which is what we all worry about with AAA, they tend to have a thrombotic problem. They embolize or they thrombose. And the risk of limb loss once you thrombose a popliteal aneurysm is very high. So identifying those is really important. This is a paper that came out of the Michigan group, and they looked at specifically this question: what is the incidence of femoral popliteal aneurysms in patients who have AAAs? This is very interesting. So in the 1990s, they found over 300 patients. These are consecutive patients treated at their institution. And they found in all of the women in the study, 62 women, there were no peripheral aneurysms associated with AAA. Now, maybe that would change if you had 1,000 patients or 2,000 patients. It's not to say that women can't get these aneurysms, but clearly it's much, much rarer. In males, there were 251 males with AAA. They found 51 aneurysms in 36 patients, a rate of 14%. So that's a fairly high rate for a problem that is dangerous for a patient to have. And I think this is the most interesting point of the entire study. Only 10 of those 51 aneurysms were appreciable on physical exam. So these are aneurysms that are there. There's a real percentage of them, and you cannot find them just by feeling. So these are patients that need to be screened. Femoral aneurysms generally require open surgery, and that's under general or regional anesthesia, depending on the size and location. Popliteal aneurysms were traditionally treated surgically, and I'll show you a couple of different ways that's done. In my practice, I treat the majority of my popliteal aneurysms surgically, but more recently we have some endovascular techniques that we can use to treat popliteal aneurysms. I have, to date, based on my experience, reserved those techniques for sort of older, sicker patients who may not tolerate an open surgery, but we'll talk about, next slide. This is your traditional open popliteal aneurysm repair. This is the back of the knee with an S-shaped incision over the crease of the knee. Usually very well tolerated. People can go home in a day or two. Next one. This is the medial approach. So this is for a larger aneurysm, depending on where the anatomy is, where the aneurysm itself is ligated on each end, and we basically do a bypass from above the knee to below the knee to exclude the aneurysm. So that's the traditional approach. Next slide. These are stent grafts that have been developed now, and these are flexible covered stents that we can place across the knee to exclude an aneurysm. And the nice thing, next slide, about this is done angiographically. It's usually done awake through a percutaneous approach. Here's an aneurysm just above the knee joint, and you can see here we've put a stent graft across that area with really nice flow down below the knee. And that's, again, done. It can be done as an outpatient even. Questions at all about femoral popliteal aneurysms? No? We're going to move down. Yeah. So what I tell patients, a stent is like a piece of chain link fence wrapped in a tube. So a stent is a metal framework. A covered stent is the same thing with a bed sheet wrapped around it. So it has some type of coating, whether it's polyester or it's PTFE or some type of material that covers it. So it essentially becomes a hose that we use to exclude the aneurysm. Now, if we just put a regular stent, a bare metal stent, the blood would be able to flow in and out of that stent. So if it wasn't opposed, you'd still have flow into the aneurysm. And the term covered stent or stent graft are routinely interchangeable. Yeah.
Did you say stents could be used for femoral aneurysms?
So the short answer is no. The more complicated, right? The main reason is we don't, and it's a good question, because if we can use them across the knee joint, which clearly has flexibility, we should be able to use them across the groin. The main problem I've found is that the deep femoral artery, the profunda, is usually involved in some way, and so you can't get an adequate seal with a stent and without injuring the flow to that vessel, which is an important vessel. And so I have not seen, now that's not to say I've never put one there, but it's usually people in extremis. It's used as a salvage.
So we used to not want to put grafts across joints because of thrombosis. Is that
Correct.
no longer a problem?
It is a problem, and if you have a 45-year-old guy who's an active gardener and always squatting and down on his legs, I would not do this. I think you're going to run into trouble. That's why I said in my practice, there was a lot of enthusiasm 5 or 7 years ago about doing this, and I ran into some problems being burned with patients coming back with thrombosis stents and needing reintervention. So if it were me, I would want an open operation today. That may change in the future because the technology is moving incredibly quickly. But I think, if you have an elderly patient who really isn't very active, this is going to be better for them and this will prevent the risk of an ischemic leg versus an open surgery, which may be harder for them to get through. We're going to move a little bit now into the abdominal segment, and this is a little bit about technology, but a little bit about stressing the point that there are older and sicker patients out there that we can treat today with the technology we have. This is your fairly standard abdominal aortic aneurysm, starting below the renal arteries and ending at the iliac bifurcation. And we're seeing more and more patients that have a concomitant common iliac aneurysm or ectasia or aneurysmal disease of the entire aortoiliac segment, which becomes harder to treat. And in the past, if this was done as an open operation, we would actually resect this aneurysm or bypass it. And then endovascular techniques caught on. Endovascular aneurysm repair became more common, and we started doing things like embolizing the hypogastric artery to shut off blood flow here, and then bringing a stent graft straight across this area to exclude that from the circulation. That's still done today, and I think that's a reasonable approach depending on the patient's anatomy. But more and more, we're seeing younger patients who still want an endovascular solution as a first-line therapy, and they're active, they're sexually active, they're physically active, and they don't want to lose their pelvic circulation. So we are having increasing ways of being able to treat this endovascularly and maintain blood flow to the pelvis. So this is one example. This is a case I did about 3 years ago, where this is a gentleman who was in his late 40s, very young, to develop an aneurysm and had a large aortoiliac aneurysm. So this whole segment was involved, both common iliac arteries, the entire abdominal aorta. And the way we treated this was by an abdominal stent graft. And then, I don't know if you can see it or not, but these are the hypogastric arteries to the pelvis. And we put a stent graft down this artery and a stent graft down to the leg on both sides. So we call them hypogastric snorkels, but the idea is that we sandwich two grafts in here so that we got blood flow down to both arteries. Next one. And this is the follow-up CT, and you can actually see there's blood flow through the hypogastric to the pelvis, and there's blood flow out the second to the leg. I'm not sure it's necessarily the first-line treatment, and this is off-label things, but it just gives you an idea of the creativity that we can employ in terms of being able to treat people percutaneously and endovascularly. This is another example, same thing. We were able to land the stent graft here in the common iliac artery, and then this is the hypogastric artery on the other side, and we approach this. You can see there's a wire in this artery, and there's a wire in the artery to the leg. This wire is coming from the arm, so we come in from the left arm, and we're coming all the way down from across the chest, down the belly, and into this artery, and we deployed a stent in here, and then we came up from the groin on this side and deployed a stent in here. And we've got flow to all the arteries, and we're able to preserve that circulation. This is a new device that is being marketed. It's not out yet in this country, but it will be shortly, hopefully. It's been submitted to the FDA, that is specifically made to branch into those arteries in the pelvis. And so again, the technology moves very quickly. We're hoping to have access to this technology in the very near future. Next slide. This is a different company's approach. Also, again, you can see here, this is the piece here, and it has a branch attached to it, and that's meant to extend into that pelvic artery. Next. So I think as some take-home points, AAA is something that we're all very aware of, but peripheral aneurysms are easy to screen with ultrasound. I think it's very reasonable that almost every patient with an abdominal aneurysm could get a popliteal ultrasound to look for associated disease. They're more frequent than they were once thought to be. Newer techniques are available now so that we can treat these patients effectively and appropriately as well as open surgery with an endovascular approach. Thank you.